Yeah, thank you very much, Ava. First, I would like to thank the organizers for their invitation for me to be here. And a special thanks to all of you who have braved the last 4 days and have stayed here until the very end. I really appreciate it. Thank you. So my talk today initially was titled as Newer Concepts in Drug-Induced Autoimmune Hepatitis. And I should acknowledge Dr. Guru Prasad Aital, with whom I have had many discussions. So what's in the name? And I'll come to this name because everybody is into this naming spree. We had NAFLD change, we had vascular disease change. So same goes with autoimmune hepatitis due to drugs. And also I'll address how often do we see drug-induced autoimmune hepatitis, how to identify and how to manage. But let me start with this vignette. This is a 35-year-old female with fatigue, anorexia, nausea, and yellowness of the eyes for 4 to 5 months. There was no itching, there was no drug allergies, and no symptoms related to other organs. And this was the liver biopsy. So this was the liver biochemistry when she first came, and that's bilirubin was 17, AST/ALT about 2 to 3 times elevated. 10 days later and 14 days later, you find that the bilirubin has gone mid-20s, and the AST/ALT about 8 to 10 times elevated. Ultrasound was unremarkable. Viral hepatitis markers negative. ANA was an astonishing high, 1:300 and 3,200. The anti-smooth muscle antibody, antimitochondrial as well as LKM were negative. And IgG was again very high, it's 2,400 milligram per deciliter. And she had other tests that were positive, was the direct Coombs test. My question is this just de novo autoimmune hepatitis? Because we don't really question patients about the many other exposure or toxins or drugs that they are exposed to. On further questioning, she was on lisinopril for the last 2 months, but when you dig into deeper, you find that she had just delivered about 4 months ago, and during pregnancy, she had been put on alpha-methyl-dopa, and as the pregnancy progressed because of uncontrollable hypertension, the dose was subsequently increased, and at one point she was taking 1,000 milligram twice a day just till the end of pregnancy. She was subjected to liver biopsy, and you'll see the extensive florid lymphoplasmacytic infiltration, as well as significant confluent necrosis. And this is the lymphocytic plasmacytic infiltrate. But importantly, she had a lot of rosette formation, as well as emperipolysis. So these are findings which are classical for de novo autoimmune hepatitis. So we applied the IH simplified scoring system for autoimmune hepatitis, and you have this. She scored 2 points in INA, IgG, liver histology, as well as absence of viral markers, giving a definite diagnosis of autoimmune hepatitis. And fellows who are here, I would just like to say that the simplified scoring system is used for a clinical case that you see in a hospital or a clinic, whereas the larger score that you use is used for a scientific or a research purposes or in an epidemiological setting. So always use a simplified score when you see a patient in the ward. Now she was put on prednisolone, 40 milligram per day, and lo and behold, after 1 week, the bilirubin decreased and the AST decreased, and prednisolone was stopped after about 4.5 weeks. And subsequently, the ultrasonography returned to normal, LFT returned to normal. And 7 years later, her liver function tests are perfectly normal with no recurrence of hepatitis. So this was a classic case of alpha-methyl-dopa induced autoimmune hepatitis. Now, as I said, there's a lot of things about nomenclature change, and autoimmune hepatitis, the drug-induced liver disease experts are also not far behind. So we got together in Spain a couple of years ago and decided that instead of calling it, initially these things, drug-induced autoimmune hepatitis is called as either drug-induced autoimmune hepatitis due to drugs, autoimmune hepatopathy with drugs, all those things. So we changed this terminology, and unlike the non-alcoholic fatty liver disease change, which was acrimonious, this was very docile. Everybody agreed to the thing without much of a problem. So the far end to the right, you'll find that if you look hard in literature, you'll always find some drugs that were initially associated with drug-induced autoimmune hepatitis. But the ones to the left, and those are possible drug association as well as highly probable, and I would like to draw your attention to a couple of things. Most of it is nowadays due to not that the olden drugs, they still cause or drug-induced autoimmune like hepatitis, but also these monoclonal antibodies as well as biologicals are more and more associated with what looks like drug-induced autoimmune hepatitis. But more importantly, if you look down, lower down in the slide, as pertaining to India, as well as the Middle East, you find that tenofolia cordifolia, that is GLOI, is classically associated with what looks like drug-induced autoimmune hepatitis, and ABBA has published it in chronic liver disease, and again Kulkarni and Phillips have published it again in chronic liver disease. It somehow stimulates the immune cells, producing what looks like drug-induced autoimmune hepatitis, and in the Middle East, it's cart that most of the men chew. So cart is chewed by men, more men rather than women, and again produces some classical features of drug-induced autoimmune hepatitis. So the question is, drug-induced hepatitis, how much of autoimmune hepatitis are related to drugs? And this is the Einar Johnson study from Mayo Clinic. You found that the 261 patients with autoimmune hepatitis, 9% of them had drug-induced autoimmune hepatitis. And again, when they looked at whether a positive ANA was seen more commonly in drug-induced versus de novo autoimmune hepatitis, you found no difference. The same thing, no difference in smooth muscle antibody. In other words, autoantibody profile does not distinguish between drug-induced autoimmune hepatitis and de novo autoimmune hepatitis. And this is about this is a study from Italy, and then drug-induced autoimmune in the DILI cohort, that was the autoimmune hepatitis cohort. And again 9%, so it's easy to remember, 9% of all drug-induced hepatitis is autoimmune hepatitis, and 9% of all DILIs are due to drug-induced autoimmune hepatitis. And again, the drugs that are listed that were commonly associated with drug-induced autoimmune hepatitis. And when we looked at whether the IgG was higher in drug-induced autoimmune hepatitis or non-drug-induced, you found that raised IgG was a useful marker to identify DILI versus other DILIs, not DILI versus autoimmune hepatitis. So then, coming to these characteristics of recent drugs that have been shown to produce autoimmune hepatitis, and this is a conglomeration of many studies. You'll find interferon, statins again, where rarely can produce drug-induced hepatitis, biologicals, and as I mentioned, tenofolia cordifolia, especially in this country, that GLOI, that produces drug-induced autoimmune hepatitis. And again, one of the clues to making a diagnosis of drug-induced hepatitis, you find that the duration of intake of these drugs has generally been a few months or few weeks, maybe varying from one month to about 2.5 to 3 months. And most of the time, it's in women rather than men that you see drug-induced autoimmune hepatitis. Now, coming to the most important thing, you need to have a diagnosis, you need to have a liver biopsy. And can liver biopsy features distinguish between drug-induced versus de novo autoimmune hepatitis? And this is a study from published in Hepatology, and you find that when they divided them into autoimmune versus drug-induced, you find that paradoxically, eosinophils is much more commonly seen in patients with autoimmune hepatitis, as well as prominent plasma cells and rosetting, as well as severe portal inflammation. Another study from Italy that looked at drug-induced autoimmune hepatitis, you found the same thing, except that there were lots of fibrosis in patients who had drug-induced autoimmune hepatitis, exactly opposite to what the earlier study had shown, and again rosetting as well as increased portal and plasma cells. And again, study from Dillon, drug-induced liver injury, when they looked at specifically, they found that portal CD24 was plus mature B cells and plasma cells, otherwise a florid inflammatory cell, lymphoplasmacytic infiltrate, is a clue towards the diagnosis of de novo autoimmune hepatitis. Now, this is a study published just few months ago. This is from King's College Hospital, London, and you'll find that exactly the opposite features are seen in this study. Patients who had drug-induced autoimmune hepatitis patients who had de novo hepatitis had increased fibrosis, increased plasmacytic infiltrate, whereas patients with drug-induced hepatitis had 18% of eosinophilic infiltrate. If you look at the earlier slide, you had the autoimmune hepatitis increased eosinophils, but in this study, eosinophils are more commonly seen in drug-induced autoimmune hepatitis. So I have listed these various studies that were published, or these are basically case studies. These Einar Johnson studies in hepatology, you find the classic drugs associated with hepatitis. Then another study from Rodriguez and published reports, infliximab as well as adalimumab, and then the Dillon group of study coming from Gabriel et al. And you'll find again it's the infliximab as well as adalimumab and etanercept, classically nowadays being associated with drug-induced hepatitis. But how do you treat these patients? And you'll find that most of the time, once you have made a diagnosis of drug-induced hepatitis, you stop the drug or just give up steroids only for a brief period of time, you find almost 100% of patients actually resolve their disease. And what happens if you, after you resolve it, is there a relapse? We have all grown, we all know that patients who have de novo autoimmune hepatitis, if you stop steroids or immunosuppressives, a majority of them at some point in time they have recurrence of the disease. Whereas patients who have drug-induced autoimmune hepatitis do not have any relapse of the disease, and that's another clue that patients have drug-induced autoimmune hepatitis. So is steroids safe in patients who have disease? Of course it's very safe, and there's no relapse unless you re-challenge with the same drugs. And this occurs perhaps in our country when they take Giloy with recurrence of the same disease. And how do you monitor these patients? And once they have become normal, you can perhaps do a follow-up liver function or liver biochemistry every few months, and thereafter once every year till over 5 years. So follow-up of immunosuppression is another way of distinguishing autoimmune hepatitis versus drug-induced hepatitis. So finally, you have three studies that have been three publications that have been that published in the last 2 to 3 years. And this is a study published few months ago, King's College Hospital, London, that compared, and I already showed you the slide, that patients who have de novo autoimmune hepatitis have a florid plasma lymphocytic infiltrates. Otherwise, features like erythropoiesis and other features that you classically was associated is seen across the spectrum, whether it's drug-induced or non-drug-induced hepatitis. And then this is the Italian study. They looked at drug-induced versus autoimmune hepatitis. The only thing that helps you distinguish between the two is liver fibrosis. If there's fibrosis, and especially advanced fibrosis, it's a clue that the patient has de novo autoimmune hepatitis, not drug-induced hepatitis. And this is a consensus statement, a recommendation from the histological criteria of autoimmune hepatitis from International Autoimmune Hepatitis Pathology Group, which they go on to say that the consensus criteria now are better for a diagnosis of drug-induced hepatitis, and indeed for all autoimmune hepatitis. And in the coming months or maybe years, you'll probably find more of these International AIH Pathology Group criteria being used for a diagnosis, not just de novo autoimmune hepatitis, but also drug-induced hepatitis. So in summary, newer drugs, especially monoclonal antibodies and biologicals, are more and more associated with drug-induced autoimmune hepatitis. There is no histological feature that is pathognomonic of drug-induced autoimmune hepatitis, including erythropoiesis and rosette formation. These are seen both across all spectrum of disease, including drug-induced hepatitis. What helps you distinguish between the two perhaps is liver fibrosis. The more advanced the liver fibrosis, the more it is not drug-induced drug-induced autoimmune hepatitis. And the newer criteria or the consensus criteria perhaps may be better at identifying drug-induced autoimmune hepatitis. And finally, the most definitive diagnosis is that drug-induced autoimmune hepatitis does not recover after you have stopped treatment, especially corticosteroid, in the ensuing few weeks or perhaps months. Thank you very much for your attention.
Yes.
Sir, great talk as usual, sir. One doubt I have is, in Kerala especially, we have people with alcoholic hepatitis who, as soon as they start developing jaundice, maybe bilirubin of around 3, they start and go and take CAM. So in these, and then there is prolonged jaundice, cholestatic jaundice. When you do biopsy also, there is only cholestasis. In these cases, how do you attribute it to, in the natural history of alcoholic hepatitis, also the bilirubin will go up. And in these cases, how do you, in your experience, how do you attribute it to DILI? Like most of these studies have this problem of, how do you attribute it to?
If this, of course, is a difficult diagnosis to make, because these patients already have an underlying liver disease, and for that matter, they have alcoholic hepatitis where the bilirubin is quite elevated. Above that, they take some drugs, and so once you take a drug, it's very difficult to make out whether it is due to alcoholic hepatitis or a progression of the same disease. Unless you have two controls where you do it, where have one control where they don't take the drug and another control where they take the drug. Very difficult. Even a liver biopsy perhaps may not help you, because both places, both groups, these patients may develop bilirubinostasis, and that's again seen in patients who have even drug-induced hepatitis.
Yes.
And especially bilirubinostasis is also seen in patients who have drug-induced autoimmune hepatitis. So short of judgment call, I don't think we can clearly make a diagnosis as to what precipitated the illness.
Very nice talk, Harshad. My question is, I don't know whether I missed it or not, but then Autoimmune hepatitis by definition is a chronic disease, but we know a quarter of them can have acute presentation, including ALF like presentation. So I don't know whether I got it right. So which means drug-induced autoimmune hepatitis, will they always present acutely, or can they have that chronic variant of AIH? The typical variant of AIH, which I said is chronic.
Yeah. That's why I think this in order to clear these doubts, we all thought if you read the consensus criteria, they all felt that patients with autoimmune hepatitis should have a chronic disease. But many patients come very acutely to you, and that is why they want to change the criteria, because if they thought empiripolysis initially was seen only in classic autoimmune hepatitis, can be seen in drugs. Perhaps the only way you can distinguish between the two is one, when you have fibrosis, because although some patients can present acutely without fibrosis, autoimmune hepatitis, but there are many patients who can present a little later with some amount of fibrosis. The more advanced the disease or more advanced the fibrosis, the more classical of it is drug-induced autoimmune hepatitis. But if you read that very extensive 11-page report, they have addressed all these points, that they feel more and more that you are probably diagnosing many autoimmune hepatitis at much earlier stage when you don't have all those classical features, including fibrosis.
I just like to add there that in our drug-induced, what we found that the autoantibodies go away in couple of months, which is far from the truth in de novo autoimmune hepatitis.